This meeting is being recorded.
So hello everyone, we are just opening the webinar right now, and we will wait a couple of minutes for the registrants to come. And as you can see, some people are starting to join. And so thank you all for being here for this webinar, for this Academy webinar on News Summit session. So we have speakers from behavioral change and pain management, and someone from self-management and chronic pain. So we're still having people coming inside. So we're just waiting to wait a couple of minutes until we have a bit more people, and then we will start officially. We will have a round until someone can present yourself, and we will start the discussion. And otherwise, I hope it's not too cold where you are, because here where I am, it's really, really cold and it's not pleasant at all. And for anyone joining a bit late and that cannot join, this session will be recorded and it will be available on the EFIC Academy platform to be watched afterwards. So don't worry. So if we want, maybe in 1 or 2 minutes, we can start the round of introduction, and then we can start the discussion. Super. Yes, I think we will be able to start the round of introduction. So maybe Dominique, do you want to start?
Yeah, willing to do so. So good afternoon or good morning, everyone. My name is Van der Velde Dominique. I'm from Ghent University from Belgium. And last time I was present here in this meeting, I presented a work on the concept of self-management and how to deal with self-management in chronic condition, and more specifically in pain intervention programs. So what we did actually is we have tried to look through the literature and to see where or what attributes could be appointed to self-management programs. And we came up with a new definition on self-management, and we are now working. There is a Delphi study ongoing right at this moment to make a checklist on what should be in your self-management program when you design a program. And we have made this checklist based on easy to answer yes or no questions. For instance, the first question in the checklist is, do you have an educational program in your intervention program? And another question is it possible for the patient to take responsibility for setting the goals that he wants to achieve in later life, and so forth? So we have about 15 different check points in the list, and that makes it easy to create self-management programs and to check it whether it is a good self-management program. So this is where we are now at this moment. If you are interested, I can show you the different aspects in the checklist, but it depends a little bit on how this Q&A session evolves and what questions there are from your side. So thank you very much.
Thank you, Dominique. Maybe we can switch to Anne, if you can introduce yourself.
Thank you so much, Laurie. Sorry, I'm Anne Söderlund. I'm professor in physiotherapy at Mälardalen University in Sweden, middle of Sweden. Västerås, Eskilstuna are our campuses. And I talked about 5 different things. So I aim to very shortly go through the 5 different things what I was talking in Dublin. And one of the things was exercise and physical activity in managing chronic pain and the evidence of that. And there are a lot of studies that has been presented and not for significant effects and non-significant effects of physical activity and exercise. And but the studies are mostly not so high in quality, in their quality level, and very often there are a lot of adherence problems for exercise and physical activity, which I think we all can relate to when we need to exercise or be more active or not. Regarding the theoretical background for behavior change methods, there are a lot of literature on this too, but it seems that theory of self-regulation is one of the popular theories that can be found behind, for example, goal setting, self-monitoring of behavior, setting graded tasks and providing rewards and prompting to rehearse the behavior. So theory of self-regulation is my tips about theoretical background for behavior change methods. Which was very, one thing which was very, I was very happy to see was the World Health Organization 2020 guidelines of physical activity and sedentary behavior that where they first time, the WHO first time said that behavior change and sedentary behavior is a strong risk factor for non-communicable diseases. They didn't say, but there are literature that shows that also low back pain, for example, sedentary behavior is a risk factor for low back pain. And this is sedentary behavior is a growing public health problem globally, what the WHO identified. And Dominique was talking about self-management of behavior. And there are very many definitions of what self-management of chronic pain, for example, is. So I'm very, very happy that you are working with the definition of this. But I wanted to lift the definition, because the self-management behavior, because it is not just one behavior. It is about managing symptoms, managing treatment, physical and psychological consequences, lifestyle changes, monitor the condition, monitor the effects of cognitive behavior, emotional responses. So the patient has a lot of things to do, a lot of behaviors to change besides the exercise and physical activity, and most probably sedentary behavior too. So patients, they are overloaded, I would say, from the behavior change point of view. And the last thing I was talking about was the problem of adherence. And some studies have lifted that graded tasks and goal setting, self-monitoring of behavior, problem solving and feedback. Those are behavior change techniques that could be positive when working for adherence in supporting physical activity in musculoskeletal conditions. So that was what I was talking about. Let's see if you have any questions about that later on. Thank you.
Thank you very much, Anne. And maybe Ivan, you can introduce yourself.
Yes, thanks. I can do that. My name is Ivan Heijnen. I'm working as a researcher at Maastricht University and Adelante. Adelante is a rehabilitation center in the south of the Netherlands, and also Maastricht University is in the Netherlands. In my presentation, I focused on different activity-related behavioral styles within the population of patients with chronic low back pain. And avoidance behavior is a very well-known and often studied style applied in this population of patients. And the free avoidance model proposes an explanation of this avoidance behavior and the negative impact of it. And avoidance behavior is defined as a decrease in physical and daily activities as a result of catastrophizing thoughts of the patient, and this leads to fear of pain or fear of movement. And in long run, this behavior will result in disabilities in daily life activities, a lower quality of life and a depressed mood, and then pain will persist and a vicious circle arises. But not all only avoidance behavior has been found and has been seen in patients with chronic low back pain, but also another subgroup of patients has been seen or are seen, and patients that will continue their activities despite pain with high or more fluctuating levels of activity and detrimental effects of overuse as a result. And this is different terms are used in literature as persistence behavior or overdoing or endurance behavior. But yeah, some challenge is that these different styles are measured with several different questionnaires, and also that these questionnaires have different underlying constructs, and that's a challenge. And earlier studies evaluating these different constructs were able to identify two maladaptive forms of avoidance and persistence behavior, namely activity avoidance and excessive persistence. And both dimensions are related to higher disability levels, and others are not. And the definition of these maladaptive styles are that activity avoidance focus on the patient's condition of being in pain rather than the fluctuating experiences of pain, whereas excessive persistence focus on doing too much and not respecting one's physical limits and experience the rebound effect of overactivity, doing too much. And based on these studies, these maladaptive styles and relating them are further evaluated and related to actual daily life activities measured with an accelerometer and an activity monitor, but no differences could be identified between both styles. And the question I had was, what is the reason for that? Is that we were not able to classify patients properly yet? Or are the measurement instruments we use to measure actual daily life activities are not good enough and we're not able to identify these potential differences? Or are there no differences between both styles? So in conclusion, and I think that is important to discuss with each other, yeah, I think activity-related styles are very important, and getting insight in these styles may be helpful to tailor the patient's rehabilitation treatment and yeah, go to the goals of the patient. That's a short summary of my presentation.
Thank you very much, Ivan. And finally, Johanna.
Hi, my name is Johanna Fritz, and I am a researcher and a teacher in physiotherapy at Mälardalen University in Sweden. And I have summarized my presentations on 2 slides that I will show to you. Let's see if it can work out. Oh. Well, my research is about developing and evaluating methods to support implementation of a behavioral medicine approach in physiotherapy, particularly with regard to treatment of patients with musculoskeletal pain visiting physiotherapists in primary health care. And we used active learning strategies to support the implementation of this behavioral medicine approach during 6 months. And we offered supervision in clinic, including peer coaching, educational material, video feedback, individual goals, self-monitoring, and managers' supportive attention. And the results looked promising immediately after the implementation intervention, but the physiotherapist's clinical behavior were not sustained at the 3 or 6 months follow-up. So it turned out that 4 of these 7 learning methods were useful for the physiotherapist's clinical behavior change, according to the physiotherapist. And these were supervision, peer coaching, blended educational material, and individual goals. And manager support would probably have been useful according to the physiotherapists, but they experienced very little support from the managers. And the results also highlighted a distinction between achieving clinical behavior change and sustaining these changes, with different impact mechanisms linked to each of these two. So what can we learn from this? Well, to support the physiotherapist's clinical behavior change when implementing evidence in practice, we need to use active learning strategies that support both achieving clinical behavior change and sustaining these changes. Thank you.
Thank you very much for all of you. And for the people who joined a bit late, feel free to put your question in the little bar below. You will have a Q&A, and you can simply type, and of course I will ask the question on your behalf to our speakers over there. And otherwise, maybe we can kick off the discussion. I think Anne and Dominique had already a topic they wanted to discuss, maybe together, regarding health and self-management. I think you were discussing a little bit the characteristic of self-management and how to define health as well.
Yeah, that's correct. But when I was listening to the presentations, I actually had a question, yeah, it might become a discussion point to Ivan about the goal setting for patients, because there is very often a difference in the goals that the patient is putting in front and the goals that the professional puts in the front. How do you deal with the changes or the differences in goal setting between the client or the patient and the professional?
Yeah, that was not particularly the topic I was discussing, but I think that is really important. I think there can be these can be different, but I think it is very important to focus on the goals the patient has and see what you can do with that. And when looking at the topic I presented last year, it was to focus on the activity related styles, and also that patients, whereas some patients avoid movements, there are others that will continue, but both styles are maladaptive. But when you are looking in daily life, how they actually perform, there are no differences between both groups. So I think that might be important, that it should be important what a patient wants to do and where he wants to go to. And that was also, I was interested in the model or the points about self-management, what these points are. So I think that is a question to you. What are these points?
Yeah, well, very interesting. I will show the points in a minute, because I have also a small PowerPoint, so I can show them to you. But I was again thinking about, because I'm an occupational therapist and we start from activities of daily living. This is the core of our profession. And that we often see that there is, even if you ask for the goals of the patient, that there could be a huge difference. But I'm going to give an example. For instance, some of the patients have the goal, well, I want to walk for about 10 meters without feeling pain, and I want to grasp something out of the ground or something like this. And others are seeing it in a much broader perspective. I want to be able to do my job, for instance, and it's sometimes there is a huge difference between how to deal with the very broad activities of daily life versus the smaller ones. And this is something that we are still struggling with, how to deal with that and how to cope with that.
Can I add to this? Yeah, I really agree, and how I see it is that if we are talking about with the patient, when we are having a person-centered perspective in the meeting with our patients and clients, then we need to go from the point where the person is and develop the goals from there on. And if we are talking about partly activities, what they have difficult to do in daily life, instead of the whole package of working. I need to get back to my work and without pain. If we are going to the activities and from activities to more closely to behaviors, what is needed for you to do this activity, and how does it feel, and so on. If we can guide the patient from in a discussion, in a dialogue with the patient as a person-centered way, towards to the behaviors, the minor things that can be changed, then that there on the discussion can, yes, you can have the overreaching goal like this, but something needs to do the work. Get back to work needs so much more. There are so many behaviors before that.
Yes, Joanna?
Yes, and I also think that it is important to remember that we should be able to evaluate if our patients have reached the goal. So if the goal is too broad or if it's not so detailed, it can be difficult to evaluate if they have achieved the goal or not. And if they have achieved the goal, I think they will be reinforced to formulate new goals. So that can also be an argument for to formulate these specific goals. I think.
Yeah. Yeah, we are now running another program, another research program on goal setting, and it's a very nice discussion. And in our research project that we are running now on goal setting, we have left the idea of smart goal setting, because smart goal setting is very often one model fits all, because you have to be so specific that if someone wants to walk for 10 meters, then yeah, it's nearly for everyone relevant. For someone who's living at home and wants to go to the toilet, and someone working in a garage needed to be able to 10 meters and so forth. So we have left the smart idea towards a clever goal setting idea, in which the goal should be contextualized in that matter that it should be specific for the specific individual, in which context he lives, works, and so forth. So this is the C from clever, the context. And the second aspect is the life narrative, in which it's always relevant to check whether there is a history about certain things, about certain meaningful activities that he had done before. What's his history? So the life narrative. And then the E is, where is the engagement from the person? Is he really engaged to get back to work again? Yes or no? So that should be in the goal. And the V stands for values. Values like I want to be independent, I want to be there for others, I want to be self-sufficient, and so forth. So these underlying values. Then the second E from clever is the emotions. What emotions are related to coping with the disease, coping with the pain, and so forth. And then the R stands for relevant. The goal should be relevant, and the goal might not be achievable. And this is where we come to, is the goal reached, yes or no? If you have a relevant goal, you, as a professional, can look at the underlying values to reach the goal. And sometimes it's more important to reach the values rather than the goal itself. For instance, if someone's saying, well, I want to get, I want to travel a lot, this is my goal. And we know from experience that it's not possible. But if the values is, I want to be with my family, I want to have shared connection with my family, then that's achievable sometimes. So if you cannot reach the goal at the end, it might be interesting to reach for the values underlying the goals. So we are now trying to find out whether clever goal setting might give some more person-centered approach to goal setting instead of smart goal setting. So this is something that we are working on now. So it might be interesting to have some kind of a discussion about that too. And it's related to self-management, I guess.
Yeah, I totally agree on that. I think that is a very important new or direction. It must be valuable for the patient to the goals he wants to achieve. And I think, yeah, I think that is very good direction. I agree on that.
Mm-hmm. Well, and I also promised to show Ivan the different aspects that are inside this concept analysis. If it is good, you should be able to see now the presentation. So there are some attributes related to really the person himself. If you have an intervention program aiming to increase the self-managing capacities of the individual, then the person must actively take part in the care process or the rehabilitation process, or how you call it. It's not that important. The second attribute, that he must take also responsibility for his care process. And the third attribute for the person is that he must have a positive way of coping with adversity, with problems, with increasing pain, with lesser abilities to perform activities of daily living and so forth. So 3 attributes to the person himself. And then 4 attributes to the person in relation to the environment. So, and firstly, the person must be correctly informed about his pain condition and the disease behind it. In the self-management program, we should also be able to make it individually. So we were talking about the goals. So he should be able to express his needs, his values, priorities. So goal setting, as a matter of fact. The 6th attribute is the person should be open to have some kind of reciprocal partnership with healthcare providers. It's giving and taking. That's something that was in the literature very important and very apparent. Then the 7th attribute, also openness to social support. We are talking about self-management, but it's rather co-management or management together with family, together with proxies, so and all other people surrounding the actual patient himself. So these are the 7 first attributes. And then we have also discovered that when it is regarding pain or another chronic condition, most of the time it is a lifetime task. We should be able to consider this in our programs that we develop. And then a lot of attributes referring to the skills that the person needs actually. So we need to take care of, to consider problem-solving skills of the patient, shared decision-making skills. Is the patient able to use resources? Can he find some things on the internet which are reliable and so forth? Can he get in contact with the physicians and all these kinds of things? So forming a patient healthcare provider partnership is very important. And then goal setting is also a self-management skill. And then the last attribute, that a self-management program should focus not only on the medical aspect. For instance, I'm going to give another example. Does the person use his pain medication in a regular time so that he doesn't feel pain when he needs to move and do his daily activities? That's medical management, because you start from the medical perspective, but you need to be able to check also the role management. Is the person able to do his roles in society? Is he a father? Is he a grandfather? Is he a worker? Is he a teacher? And so forth. So his roles should be able to, or we should be able to tackle the roles as well in an intervention program, and also consider emotional management. So these are actually the attributes that we have reframed into questions in a yes and no checklist. which we are running now in the Delphi study. I hope that this gives a little bit an answer to your question. I'll stop sharing.
Yes, thank you very much. And actually, someone had asked in the chat if you could share the checklist of self-management program with also the clever acronym. So I think you partially responded as well, but maybe if you have a link and anything in this, you can put the link of thing that you want to share with the delegates in the chat. They will be able to see it. And
that's good. I'll put it in the chat. What we have now, I can put the checklist for the self-management program. I can put the Delphi study in there. And then you can administer the Delphi and I see all the points. We aim to publish this in BMG Open. And I will send also the attributes, which has also been published yet in BMG Open. And the clever acronym, I'll put it in the
chat.
In the chat, yeah.
Thank you very much. And otherwise, we received a question for you, Ivan, which was, you mentioned exposure in vivo as a tool for avoiders and mixed performance. Are there other proven effective techniques?
Yes, there are other techniques. I think it is for patients who have fearful thoughts. I think it is, and catastrophizing thoughts, it is important to have attention on that in treatment. And exposure in vivo is one of the treatments that has focus on that and challenge the patients to challenge their thoughts about their catastrophizing thoughts about, for instance, that lifting, for example, get injured to the back. Other techniques, I think that also in ACT, acceptance and commitment therapy, there is focus on these thoughts. So that is also, I think, a good treatment option. And also, when these catastrophizing thoughts are not so prominent, you can also graded activity or gradually increase their activity level and focus on the patient goals. And then I think there is also overlap with other presentations of us. I think that is very important. But when these catastrophizing thoughts are very prominent, I think that should be a part of attention in treatment, because that will have impact on actual today's functioning, but also on long run is I think important for relapse of disabilities.
Super. I think you're so if the person who asked the question has any more questions, please feel free to indicate them. And we receive otherwise another question, which I think is for you, Anne. In obesity, behavior change techniques seems to be effective only in the middle term. What is recommended for long-term effects?
Yes, it is a very good question. And when we wrote scoping review about adherence, older persons with chronic pain adherence to physical activity and exercise, we just couldn't find literature for maintenance, the behavior change strategies for maintenance. It was so difficult, but we did one. There were not studies on that that one could draw any conclusions. But what we did do was that we found from different books that kind of literature, what is suggested could work in a long term and maintenance, supporting maintenance of behavior. And there are, just a second, I have a slide here, maintenance. There are strategies that are about identifying high-risk situations for relapse, pain coping skills for problem solving for high-risk situations and lapses, Goal setting is there also, and they are have been identifying that kind of strategy. Self-monitoring of behavior and progress, and self-regulation in general. Also environmental triggers of relapse, and identifying these environmental triggers of relapse, and problem solving of high-risk situations and lapses by using social support, as Dominique was into. And social enforcement also from significant others could be those kind of strategies that could support in long-term maintenance of exercise behavior and physical activity behavior. But that is a tough question and needs to be studied so much more.
Which I'm sure it is by many people around the world. And otherwise, I have actually a question for Joanna. And I was wondering, because we have a good example here with the self-management checklist from Dominique. So what would be, for example, if one of our attendees wants to implement this checklist into their practice and in their department, what would be the different steps that they should do to implement this new practice in the department and
Well, that's a very relevant question.
So just, Dominique, that would be only for Joanna because it was really her.
Yeah,
I'm
so.
sure you will be able to answer some question related to what Joanna answered.
Yeah.
Okay. Well, I think it is important to be aware of the way that we support the implementation of this checklist. And according to me, I think it is important to use these active learning strategies for the professionals that will use this checklist. And with active learning strategies, I mean the possibilities to try to use the checklist, to discuss problem-solving strategies when using it, to discuss with colleagues how to use it, and been able to reflect on the positive outcome when using this checklist. So I think it is the active learning strategies that is of importance when you implement this what do you call it?
Like the checklist or
the checklist,
practice,
yes, the checklist. Or whatever you implement, I think it is important to use active learning strategies, because we have seen that when you use only passive learning strategies, the professionals, they increase their knowledge and their attitudes, but they don't change behavior.
Which I guess might be similar to patients in a way. That you have similar strategy for the professional and the patient on how to learn a new method for themselves or for the practice.
Yes, and we have talked a lot about goal setting, and we have talked about goal setting in relation to the patients, but actually it's important to set goals when you are implementing things too, goals for the professionals.
Yeah.
And so Dominique, how would you distribute and share your checklist? Or do you, as it's your baby in a way, so how would you see it implemented, and what would be maybe your suggestion on top of Joanna's suggestion of active learning and active implementation?
Well, it's very interesting what Johanna is putting forward. At this moment, it is what we call, and Ivan will understand this, we call it koffiedik kijken. That means the coffee is so thick that we cannot see through it. So at this moment, it is a little bit difficult to see or to know how we are going to implement it at this time. So we are in the phase now or developing the checklist, and the follow-up study is, well, how are we going to implement it? And we are going to use the EFIC framework. That's the consolidated framework for implementation research, in which we try to see what are the strengths, what are the weaknesses, a little bit like a quality control system to see how we can implement indeed such a checklist in the real practice, but we are not there yet. So it was very interesting to hear the ideas about Johanna, to see what her ideas were. Thank you for that.
And so all panelists have questions, so I think you can just jump ahead.
Yeah.
I think Ivan, you were first.
That's great. But maybe can you give a suggestion, Johanna, what active learning strategies you would prefer to implement it?
Yeah.
Or example in general for what do you prefer? What kind of active learning strategy to implement a new intervention?
I think you need to support the practice of the intervention, not only inform about the checklist, but you also need to get the professional to practice. And how can you get the professional to practice the checklist? Well, I think one thing can be to set goals.
Mm-hmm.
Set goals for the practitioner.
For the
For the professional, yeah.
Yeah. Another thing, it can be like supervision. And I also think the support from peers or colleagues and support from the managers are very important to encourage the professionals to try to use the intervention that you want to implement, such as the checklist. But I think you need to try to use it, and then you need to be able to discuss with someone, for example, your colleagues, what is the challenges when using this checklist, and how can we solve these challenges? So you had the support from the other persons that you work with. And I also think it is very important that you involve all the professionals that work together. So it's difficult to implement an intervention, if not all the professionals are on the train, so to say. You need all the professionals need to try to implement this checklist. If it is only one or two persons working at a clinic, it is very hard to implement an intervention.
Yeah.
And Anne, I think you wanted to say something.
Yeah, I just wanted to, since I do know your project, Johanna, quite well, I just wanted to suggest, could you say something about this external and internal motivation?
When we try to implement intervention, we often use this extrinsic motivation. We have someone from the outside supporting this implementation. And that can be very effective, but it can be a problem in the long term, because when this person or this driving force are disappeared from this from the clinic, when the implementation period is ended, then it is possible that the behavior change of the professionals will go back from where it began. So I think it is very important to support the intrinsic motivation. And one source of intrinsic motivation can be like self-rewards or self-reinforcement. And the reward that the physiotherapists in my study experience when the patients improve due to their treatment is a source of intrinsic motivation. However, when treating patients with persistent pain, the improvements are not always expressed as reduced pain. So sometimes the pain is the same, but the patient's ability to participate in activities in daily lives is increased. So the success of the treatment approach needs to be highlighted for the physiotherapist. And sometimes it's not about increasing pain, it's about or decreasing pain. It's about improve the patient's ability to participate in daily life activities. But
like
another tool to achieve...
improving the quality of life.
Yes, exactly. But another tool for this intrinsic motivation is, as we already have discussed, by setting goals. So by setting goals for the professional, it can also, and reaching these goals will increase the intrinsic motivation. So we need to find ways to support how to use goal settings for the professionals and how to reinforce the goal achievement. And for that, I think the managers plays an active role.
Very interesting. I'm sure our attendees will take all this information to implement their own new practice, new method into their clinics. And otherwise, everybody listening, feel free to contact EFIC. And if you need, we can always put you in relation to one of our panelists if you have further questions. And otherwise, we receive a question for you, Anne, which was, you mentioned self-efficacy as a tool to improve exercise adherence in neck and low back pain. Is a multidisciplinary approach recommended?
Yes, self-efficacy concept, by the way, is my favorite nearest my heart concept. I love it so much because it is so positive, and it awakes positive feelings in patients too. That is, when you are success to do something, when you are reaching your goals, it doesn't matter how high or low the goals are, but if you are reaching, then you are getting higher self-efficacy in doing that certain behavior. And the multidisciplinary approach I think it is always important, not only in self, of course, I think you who posed the question think so too, but in self-efficacy topic, it is important that all the team members, if we are talking multidisciplinary team in pain context, all the team members all kind of have this want and need for the patient to succeed in something. It doesn't, as I said in the beginning, it doesn't matter how small things they are succeeding, just that they feel that, yes, I did it. That is so important for the behavior to go on and the person to want to continue with that kind of behavior, whatever it is, part of self-management or exercise or whatever it is. So as a team member, we all need to agree that, yes, we will support to get the patient's self-efficacy higher in that behavior and that behavior and that behavior.
So it's a strong group effort from everyone. And I'm sure, Ivan, you also have this the same similar issues or way to troubleshoot with your patients.
Yes, I think this is very important. You have to get success with the patient, and then go on and on and on and reach these goals. And yeah, I think there is some overlap how we can implement and see new strategies for the practitioners, for the therapists, but also for the patients. Clear goals and do it in practice.
Yes, Anne?
Yeah, and I just associated to research area that there are so many people outside in the world who has chronic pain, who never seek any care, who never goes to any occupational therapist or physiotherapist or psychologist, whatever. They never seek because they manage it, because they can handle it. That would be so important and interesting, really interesting to study those people. But unfortunately, often we can't find them, and they don't want to be in the studies. Either they don't have time because they are managing their life so well, and that their life is full of challenges without our studies. But that would be so nice to know what is happening really, how high their self-efficacy is in different behaviors, and what are they doing, how, why, emotions, thoughts, cognitions.
Yes, and mostly how they manage any obstacle that come across them in order to move forward. Because I noticed in a few of your presentation, you talked about helping the patient going through the obstacle, and also for the implementing, also for the professional, if they have any issue implementing any practice, how do they deal with this issue, and are they able to actually ask for help, either as a patient or as a professional alone? I'm having an issue moving forward. I have an issue with putting in place this method, and I don't know how to process this emotion, and I don't know how to go through it in order to continue to implement this new method in my daily life or in my daily practice. And Jonna, apparently you have an answer for that.
No, but I was also thinking about that. We are talking about self-management and self-management strategies, and we are talking about goal setting, and we are talking about self-efficacy. And actually, when we are talking about these things, it doesn't matter if we talk about changing our patient's behavior or if we are changing the professional's behavior, because these strategies are important both when we talk about patients or if we talk about professional or ourselves.
And so we are getting actually quite close to the end of this webinar, I just realized, because the discussion was really interesting. And actually we had maybe a last question we see, and I think it's for Ivan, which is excessive persistence is associated to depressive symptoms, and how do you support such patients?
Mm-hmm. Yeah, that is an important question. We have not studied that yet, but I think it is important to look at also in line with what we discussed now. Look at the goals of the patient and make successes reaching these goals in small steps, and get the focus on the things that he can do, but step by step go further, and then I think that it will also have a positive influence on the depressed mood of the patient. So focus on what is important for the patient, his or her goals, and then step by step go further, and hopefully this will have impact on his mood.
And would you recommend to send them towards a psychologist, maybe linked to
Yeah, I think an interdisciplinary treatment that is very important. So go for the goal of the patient and use the different professions. So the physiotherapist, the occupational therapist, the psychologist, and step by step together for one goal of the patient, and working together in a team.
I think like you said, and Anna, you need the whole team to work together toward a similar goal, to make sure that it's a strong work for the professional and the patients.
Yeah, so I think you are working indeed for one patient, and a patient want to reach his goal, and not one goal for the physiotherapist and one goal for the occupational therapist and one goal for the psychologist. No, he wants to go back to work or doing his hobby, and I think we have to collaborate then as a team.
Fantastic. And because we have only 5 minutes left, maybe I would like to have a last round. And if you have anything that you would like the attendees to keep in mind by the end of this webinar, what would it be? And maybe we can start again with Dominique.
I think it was a very nice discussion. I have learned a lot. I have written so many things down on my papers. So for me, it was a very good seminar. I hope it was for the attendees as well. But I don't have anything else to add. Just keep up with the good work that you're all doing, and have a nice day.
Thank you. And you put, the link for the,
yes.
I think Delphi and etc. So that is great. And Anna, maybe you want to pursue?
Yes, I do agree with Dominique. And my last words, oh, that sounds so good. My words, final.
Yes.
Yeah, it would be that if you are doing research in chronic pain and interventions, plan already from the beginning how this intervention will be implemented in the real practice, but also plan. I hope you are applying behavior change strategies in the intervention, and plan to have different kind of strategies for adherence to whatever behavior you're working with the patient, and also maintenance. So don't forget adherence, maintenance, and how to implement after this intervention. What should I do then? But the clinicians do, yes, not only researchers, but the clinicians do think at least maintenance and adherence.
No, that's really important. And you, Ivan?
Yeah, I think it was an interesting session. I liked it at least. So I have nothing to add. Thanks you.
Very good. How about you, Joanna?
Well, I think that active involvement is very central in what we have talked about today. And it doesn't matter if we talk about the patients or if we talk about professionals. I think active involvement is a core concept because the patients need to be actively involved when setting goals, for example, and the professionals need to be active when learning new strategies for their clinical work. So active involvement.
Thank you very much. And indeed, it was really, really interesting. And I think that's why, and we had some interesting questions. And I think I think our attendees were mostly interested in what you were talking about with each other, because it was really complementary. And you had some really important key points on how to implement either new practice and also the self-management checklists. And people will be able to use them directly tomorrow into their practice. And I think it's what is important. And that's why we try to offer also at the academy, the EFIC Academy. And I would like to thank you, all of you, for having there and for this really, really interesting question. And if you have any question or if you wish to pursue the discussion by email, do not hesitate to contact each other or contact us so I can put you in contact. And thank you all. And I wish you a nice afternoon and maybe a good holiday in advance.
Thank you, Larian, and bye-bye you all.
Thank you.
Bye,
See you
everyone.
next session somewhere.
And bon appétit.
Oh, yes. Certainly.
Bye-bye.
Bye-bye.